Good morning, everyone. This is the Orlando GI Journal Club. This is September 3rd, 2025, 7 a.m. Eastern Standard Time. Our first study is on endoscopic balloon dilation with steroid injection versus radial incision and cutting with steroid injection for patients with refractory esophageal strictures. This is by Aoyama et al. In Endoscopy. Anastomotic stricture is one of the most common complications after esophagectomy, and it is usually treated by endoscopic balloon dilation or savory dilation as the initial treatment. However, there is no standard treatment strategy for anastomotic strictures that are refractory to repeated dilations. Local steroid injection is reported to improve efficacy of endoscopic balloon dilation and has been shown to significantly decrease the number of dilations required to resolve the stricture. Radial incision and cutting method involves cutting through the fibrotic tissue at the stricture site with electrocautery knife and removing the fibrotic tissue to prevent stricture recurrence. And the aim of this study was to evaluate the efficacy of radial incision and cutting plus steroid versus endoscopic balloon dilation plus steroid injection. This was a randomized trial conducted in Japan involving 32 hospitals, patients with refractory anastomotic strictures after subtotal esophagectomy for esophageal cancer, after at least endoscopic balloon dilations were enrolled. Patients were randomized in a 1-to-1 ratio to endoscopic balloon dilation plus injection of triamcinolone, 40 milligrams, versus radial incision and cutting plus steroid injection using triamcinolone again. The primary outcome was the comparison of adverse events. 65 patients were enrolled in the balloon dilation group, 65 patients in the radial incision and cutting group. In terms of the patient demographics, they were comparable as you would expect in a randomized trial. The median age was 68 and 69 years for balloon dilation and radial incision and cutting groups, respectively. In terms of the construction of anastomosis, the majority of patients had stapling of the anastomosis, 69% in the balloon dilation versus 77% in the radial incision and cutting group. The estimated diameter of the stricture was 2 to 5 millimeters in 39% in the balloon group versus 49% in the radial incision group. The median number of anastomotic dilations prior to enrollment were 5 in both groups. In terms of sessions of dilation for a stricture before enrollment, the majority had undergone 6 to 10 dilations, 26% and 27% respectively, followed by 3, 4, 5, and some patients had even undergone 11 to 20 dilations. That was 10.8% versus 7.8% in the two groups. 9.2% in the balloon dilation had a history of radiation, 7.8% in the incision group had a history of radiation. The interval from surgery to the first dilation was less than 90 days in 74% in balloon dilation and 79% in the radial incision group. In terms of the primary outcome, grade 3 or 4 adverse events were encountered in 2 patients in each arm, which were not statistically significant. When comparing stricture-free survival, it was 10.6 weeks in the balloon dilation compared to 8.7 weeks in the radial incision group with a p-value of 0.82. The median number of balloon dilation in 24 weeks after the initial treatment and enrollment was 1 for balloon dilation and 2 for a radial incision group with one-sided p-value of 0.99. So there was no significant difference between the two groups. In terms of the limitations, participants in this study had strictures that were milder than previously reported studies of patients undergoing radioincision and cutting. And the authors speculated as to whether this might be why the radioincision group didn't perform as well as the authors had anticipated. The depth of incision was determined by the endoscopist performing the procedure for radioincision and cutting, which may have resulted in inadequate incision in some cases, and again may account for the lack of anticipated success of radioincision compared to balloon dilation. The take-home points is that radioincision and cutting plus steroid is not superior to endoscopic balloon dilation plus steroid, and therefore is not recommended as a routine treatment. Endoscopic balloon dilation with steroid injection therefore remains standard of care for patients with refractory anastomotic stricture after partial esophagectomy. Our next study is in Gut by Yamada et al., looking at the precision risk stratification of primary gastric cancer after eradication of H. pylori by a DNA methylation marker. Risk stratification of primary gastric cancer in healthy people after H. pylori eradication is needed since the number of this population is rapidly increasing, and gastric cancer can develop in 0.5 to 1.2% of this population. Accumulation levels of epimutations, which are essentially aberrant DNA methylation, namely epimutation burden, in non-malignant gastric tissue can be measured by DNA methylation marker and are correlated with cancer risk by multiple cross-sectional studies. However, the utility of a DNA methylation marker for risk prediction of primary cancer in healthy people after H. pylori eradication has not yet been confirmed by a prospective study. The aim of the study was to confirm the clinical utility of a DNA methylation marker for epimutation burden in healthy people after H. pylori eradication with open type gastric atrophy, all of whom have clinically high risk. This was a prospective cohort study conducted in Japan. Adult healthy people after H. pylori eradication with open type gastric atrophy were enrolled. After enrollment, 2 biopsy specimens were taken from antrum body for DNA methylation analysis, and DNA methylation levels of a marker gene, RIMS1, were measured in biopsy specimens from the gastric antrum body. The patients then underwent annual EGDs to diagnose any primary gastric cancer for 5 years. The primary outcome was to compare the incidence of primary gastric cancer in the quartile with the highest methylation level of the Q4 of a pre-selected DNA methylation marker, RIMS1, with quartile with the lowest methylation level, Q1. A total of 1,624 participants underwent at least one endoscopic follow-up. The median follow-up duration was 4.05 years. The primary gastric cancer developed in 27 of these 1,624 patients. When looking at all the participants, the median age was 64 years. The male and female predominance, the male and female makeup was similar, 49% men, 50.8% females. And if you look at the demographics of patients who were diagnosed with cancer, the median age was 68 years, 52% were men. And if you look at the methylation level, the maximum was 25% in cancer patients, compared to 10.2% when looking at all participants. When conducting comparison of the incidence of gastric cancer between patients who did and did not develop gastric cancer, and you compare the incidence according to the maximal RIMS1 methylation level, As you can see, just by looking at the numbers, the number of cases in patients with the highest level of methylation was associated with the highest number of gastric cancer cases, 15 in Q4, compared with just 2 in Q1. Now, when you convert it to the incidence rate, that translates to 127.1 per 100,000 person years in Q1, compared to 972 per 100,000 person years in the Q4 group. Now, when looking at the adjusted hazard ratio, taking Q1 as reference, the risk of developing gastric cancer in Q4 is 5.7. The hazard ratio is 5.7 when compared to patients in Q1. And this was statistically significant with p-value of 0.023. When looking at the cutoff methylation level, at cutoff methylation of 25.7%, they were able to obtained to identify a population with a super high risk based on the number needed to screen of 1,000. The limitation of the study is the small number of cancer cases, only 27. Also, patients who developed gastric cancer in the upper stomach, they report, or this is the supplemental file, had a significantly lower methylation levels than those who developed gastric cancer in mid or lower stomach, while levels were still significantly higher than healthy people who had never been infected with H. pylori. This suggested that gastric cancer in upper stomach is related to, but less related to, epimutation burden accumulation than those in middle and lower stomach. In conclusion, a DNA methylation marker can risk stratify healthy people after H. pylori eradication, even though all of them have clinically high risk. Individuals with super high risk will need more frequent gastric cancer screening than currently recommended. For the general club recap today, radial incision and cutting plus steroid injection is not superior to endoscopic balloon dilation and is not recommended as routine treatment. Endoscopic balloon dilation with steroid injection therefore remains standard of care for refractory anastomotic stricture after esophagectomy. 2, a DNA methylation marker can risk stratify healthy people after H. pylori eradication, even though all of them have clinically high risk. Individuals with super high risk will need more frequent gastric cancer screening than currently recommended. Thank you so much for joining us this morning. Next monthly GI Journal Club will be October 1st, 2025. Please have a wonderful day, week, and month, and have a wonderful September. Thank you. Bye.